So we're going to talk about the mechanics of working with hospitals. So I think I said a little bit in the beginning, there are rules, there are guidelines, there are applications, there's a process for starting this engagement beyond just the relationship building. And so we have 4 people here to kind of talk us through some of the puzzle pieces that I have up here. So starting research at Grand River Hospital, the ethics review process, engaging with public health units beyond Grand River Hospital, and some of the funding opportunities that you could take advantage of for the projects that you're interested in starting. So to kick us off, we have Sarah here. She is a research office administrator at Grand River Hospital, and as Tina mentioned, she also has a shared role with the University of Waterloo. And so she's my partner in crime for the Pizza with the Prof sessions. We work together on that. So yeah, Sarah's gonna start us off with the whole process of how we get going. Here's your clicker, and you can stand here or you can walk.
I'll stand here, thanks. Good morning, thank you for having me here this morning. I know we'll start out immediately by answering the question of how do you get connected with someone at the hospital? So researchers traditionally have been on their own to make that first connection into the door. So unless you happen to know somebody, perhaps you went to school with somebody, you met them at a conference somewhere, that has been your traditional walk through the door. You may have made a phone call into a program and someone happened to answer the telephone that said, sure, I'll meet with you. But what we've tried to do is make a more formalized process, and that's where my role at the hospital has come in. So we have started to try and make some opportunities for researchers to get together with clinicians. We have held 3 meet and greet sessions that specifically targeted focus that was aligned with the hospital and university research agenda. So as I said, we had 3 sessions. We've had over 100 participants from both the hospital and the university at those. Another opportunity that we've created with CBB is the creation of the Pizza with the Prof sessions. So once a month at the Freeport site, we're having a researcher come in and present their research topic. It's an informal opportunity. There's some conversations back and forth with the audience. We've been averaging about 40 participants from the hospital. They've been clinicians from OTs, PTs, physicians, nursing. They're quite interested to hear what's happening here, and they're quite vocal about stepping up and saying, I don't think that's going to work. You might want to consider streaming it down this line. If you want to get on that list of topics, you should see KEMA. We'll start up again in the fall. And then certainly the open door is always through our office. So as we've mentioned, my position is funded by the University of Waterloo. I'm always happy to have a telephone call, have an email. Let me know what you're interested in. Let me know the topic that you're exploring, or is it a specific clinician that you have some interest in? And I can certainly help make those connections. During the first year of our partnership, we had 14 inquiries that came directly into my office, and I was able to match 12 people up. So you've made your partnership, you have an idea, you're ready to actually start into an application process, you should hit the hospital website. You can certainly call me and I will tell you everything that's actually listed right on the hospital website. You'll find the ethics application package, a template with the research data agreement, and a listing of some of the hospital policies related to research. So research at the hospital follows a 2-step review process, beginning primarily with the submission of your research application to the research committee. So the research committee assesses researchers for the impact on hospital resources and determine whether the research meets the goals and objectives of the hospital. The second stage of your approval process is your ethics review, and we'll leave Julie to talk more about that coordinated process now that we have with ethics at Grand River and ethics here at UW. And finally, once you've been through both of those gates of approval, you'll receive permission to proceed to have your research commence at the hospital. The research committee and THREB have timed their meetings very closely so that an application can proceed in consecutive months through both processes. So for an example, if a researcher was presenting in September to the research committee, they could then proceed the next month to go to ethics for review. So we have tried to streamline our processes so that multiple things can happen simultaneously. So as an application is moving through the research committee and ethics approval process, a secondary step of having a research data agreement and a contract can be reviewed in parallel to that. So the hospital does require a research data agreement for any research study that's collecting personal information or personal health information about subject matters. So a draft research data agreement, our preference would it would be submitted at the same time as the research application is done, and the RGA review is conducted by the hospital's privacy department. In some cases, such as industry-sponsored studies, we do request that a contract is negotiated between the hospital and the sponsor organization. We try to identify those as early on in the research process as possible because contract negotiations can take some time to work out between all organizations. The main thing to remember through the entire process is that once you receive your ethics application has been approved, you must have your research RDA signed and your contract signed before research can actually commence at the hospital. And at any time through any of those steps, from the inquiry to ethics approval, our office is certainly always available to answer any questions that you have along the way. So of course there's Tina and I in the office. The THREB office is actually located at Grand River as well, so Dr. Michael Coughlin. And nicely, Lori Dietrich, the THREB office administrator, also works part-time in our office. One of the main missteps we see in researchers is that they submit directly to THREB. They've missed that step of coming to the research committee, and having that link with Lori means those things are quickly identified and we get things back on track rather quickly. Thank you.
So we'll do questions and answers. Sorry. We'll do questions and answer session at the end of the mechanics section. So now I'll introduce and stand up very tall. Julie, who's Senior Manager for Research Ethics, and she's going to talk about the second half of this process.
So thank you. So yes, as Sarah was mentioning, we do have a coordinated ethics review process now with Grand River. So between Waterloo and Grand River, our objectives were really to try to promote multi-site research among our institutions. And we wanted to streamline the ethics review process by having a single point of contact for the principal investigator at their home institution. So if you're a Waterloo investigator, I'm your point of contact. If you're a Grand River Hospital principal investigator, Michael, the chair of the THREB, would be your point of contact. And we want to eliminate the consecutive review that often people experience when getting ethics review for multi-site. And what we mean by consecutive review is applying at one institution, waiting to get approval, and then applying to the second institution. It creates greater length of time to get ethics review, and so in our case we can combine these and do them simultaneously. So what it means for researchers is one application form getting one set of review comments and one ethics approval or notification letter from both institutions. So it saves on the paperwork as well. And for our agreement with Grand River Hospital, and in actuality, because the THREB is the Research Ethics Board for St. Mary's and Cambridge Memorial Hospital, it covers those hospitals as well. So all research, regardless of the risk level, greater than minimal risk or minimal risk, can go through this coordinated process. So the agreement with THREB was signed on December 21st of last year, and to date we've had 7 applications go through our coordinated review process. 3 of those went to full committee review, with the remaining going through delegated review. Delegated review is typically one member of the REB reviewing those applications. So the fortunate thing about THREB and the University of Waterloo Clinical Research Ethics Committee, which most applications go through here at Waterloo for the type of research that we're seeing joint with the hospital, is that our meeting is on Tuesday evening, the THREB meeting is on Wednesdays. at the beginning of every month. So we could have not timed that any better. So what it means is both of our committees are meeting within a day of each other. Within a few days, Michael and I are talking and pulling together the review comments, and by the following week, researchers are receiving their feedback from both of the REBs. So they get one set of comments from both of us. So as Sarah explained, it is a two-step process for getting approval to do research at the hospitals. One is the administrative, or I guess research committee approval that you have to get from the hospital first, and then second is applying for ethics clearance. Here at Waterloo, we are looking at a new online database system, so in future, researchers do not have to kind of populate our database to the extent that we're asking them to do it right now. So we will be changing that in the future, but right now it's completing the THREB application form. That's what we're doing. You have to do that as part of the hospital approval process. Then you populate our database, and it's essentially a cut and paste from their application into our database to give us the information we need to create a record and track the research as well. You submit the application, all the materials, to whoever is the PI's home institution. So if you're a Waterloo investigator, you'd submit it to us here at Waterloo Ethics Office. If it's Grand River, it goes to the THREB office, and then we coordinate everything in the background. Amendments or modifications to the research are also done through this coordinated process, and we are using the THREB application form in that case as well. The only thing that is not coordinated is reporting problems, so adverse events, protocol deviations, incidental findings, anticipated problems, those do have to be reported separately, and typically the incident is probably happening at the hospital. You want to get to them immediately, and then you can follow up with us in the following day or so. Annual renewals, it is a requirement of the Triad Council policy statement that both of our institutions follow. That research has to be renewed on an annual basis, so you do have to renew at both institutions on an annual basis. And of course, reporting the study is closed. You need to let us both know of that. And we don't have joint forums at this time for any of those, but it is something we could be looking into in the future. So to wrap it up, I put a link here. I don't know if the slides will be posted or anything, but here's a link to the details of the joint review or the coordinated review process between our two institutions. I have a few handouts that I brought from that link. If anybody wanted to take a paper copy away, just see me after. And then here is our contact information, and I put Lori's up there as well.
Thank you very much. So we've gone over the Grand River part of things. So now if you would like to engage in research outside of Grand River, Vlad's going to talk to us a little bit about that, introduce himself, and let us know what he does in the Office of Research.
Thank you, Kim. Hi, everyone. I'm excited to be here, mainly because building partnerships is really my forte. So the Office of Research introduced this role in December, and essentially I have three core functions. Number one is I work with researchers one-on-one. So I meet with researchers to get a sense of their current research interests, past projects that they've done, stakeholders that they've worked with, and their interest in applying for grants. So once I get a sense of what they do and what their interests are, I engage with public sector units, which includes public health units, community health organizations, grassroots NGOs that deal with whether it be population health, social determinants of health, mental health, etc., to find synergies between the work that's being done at Waterloo and the work that's being done in public health units and public sector entities. Once I find those synergies, I then create those introductions between faculty and those NGOs or public sector entities, right, to create those relationships and nurture those partnerships moving forward. And the third role is working with foundations and being creative with that. So what does that entail? So aside from looking at foundations and looking at who's eligible to apply, it's also bringing the community partners with the researchers and applying for those funding opportunities. So I've seen some challenges when I've met with public health units and looking at how these partnerships are developed, challenges that they've had with working with researchers, sometimes maybe feeling siloed from the process. And for me, it's really to nurture those relationships with the researchers and those public health units. So opening up those, lines of communication to make sure that letters of support are taken care of and that, the researchers engage with the community partner and vice versa. So really looking forward to working with everyone. I do see some familiar faces here, and I can't really stress it enough that it's really important that I meet with researchers and get a sense of their work, because at the end of the day, if there's a strategic gap or a priority within a public health unit or a community health hospital, or grassroots organization, that work actually might be something that someone here at the university is doing. And it's as simple creating an introduction or a link, site visit, etc. So really looking forward to working with everyone else here, and I can't stress it enough that it's really important that I meet with as many researchers at the university as possible. So thank you.
Okay, last but not least, the money part. Everyone's favorite section. So Leslie Kopp from Office of Research will be talking to us a little bit about the funding opportunities for engaging in hospital research opportunities. And your favorite mic is right there.
Yeah, give me the hard part. Finding the money is without question a challenge, and rather a larger challenge these days, I have to say. I'm actually going to focus on CIHR today, fully admitting that CIHR is not a particularly happy place right now. They are in the throes of massive reforms, which are unfolding in a lumpy fashion. And of course, we're facing quite possibly this round of single-digit success rates. So I can't say that it's a joyous place. However, it is likely the most appropriate source of funding for collaborative health research. However, as Vlad said, there are also other possibilities. A lot of the NGOs and public sectors don't necessarily have the money to pony up, although they might, but they also might bring powerful partnerships to help you get funding, and there are foundation possibilities as well. So I don't want to belittle those at all, but I can't talk about all of those writ large, so I am talking about the large juggernaut that is CIHR and trying to understand. You have to learn hospital dialect, and you have to learn university dialect, and you also have to learn CIHR speak. So I'm going to try and give you some CIHR speak. And I'm literally going to start with some key definitions, because you need to know these to understand all the permutations and combinations that are available to you in applying to CIHR with hospital partners. So, applicant. You think, yeah, applicant. Well, at CIHR, in fact, and this will help build those relationships with both community hospital clinicians and teaching hospitals as well. You can have an independent researcher, which is your typical academic, can supervise students, publish papers and everything else. But you can have an applicant at CIHR that is a knowledge user, someone in the hospitals, and it doesn't even necessarily have to be a clinician. It can be the systems support when you're looking at actual systems, not necessarily widgets that will dialyze better or drugs or anything else. So an applicant level is basically they are going to take part in the research. They're an integral part of designing the direction of the research question. You can have knowledge users at that level in an application. A collaborator is a little less engaged, so it's important they come with a specialty. They'll either have access to a particular patient population or data or a system or a special mouse or whatever. So a collaborator will be involved in the research, but not necessarily at the direction of the research. A knowledge user, so I've sort of talked about this already, is a person in a position to translate the research into activity, into operation. So that's the level. They don't have to be an academic. They are actually able to impact it being used. So you will actually need someone as a knowledge user who can influence the use of whatever the research is, the application thereof. Then partner, this is the big one that people keep getting confused on. Partner at CIHR, capital P partner, is an organization. It is not a person. It is an organization, an institution. To be a partner, you have to contribute cash or in kind, we'll be talking about in a minute, and play a role in the knowledge translation or the commercialization or moving it forward. So that's an organization versus an individual. The academic hospitals actually can be partners because technically partners aren't the non-academic, they're the useful. So at an academic hospital, if you're working with that instead of something like a community hospital, it just has to be from the clinical side. It's the applying whatever research you have as opposed to the researchers like Helen referred to where they just want to get the papers out and be part of the research. Those would simply be an applicant, a co-applicant, and their hospital would be the source, not, or would be the home institution, not a partner. So, you can partner with a hospital in all kinds of different ways. It's wide open, which is really good news, actually, because whatever makes sense is what you can do. You can have independent researchers from hospitals, so those will be people who can be your co-applicants or other principal applicants. If from a community hospital you're doing that, and we can, it probably means that the clinician will have to have an adjunct appointment at an academic institution. So if you want to get engaged on that level, on the independent researcher point of view, especially at a community hospital like GRH or any other one, you've got to add extra time in to make sure that that clinician has an adjunct appointment, and that can take time. In negotiations, it's not as simple as just jotting it down on a piece of paper. So that's one level, that's one tip of if you want to do this. It's certainly possible, but there's extra hoops you have to go through. The knowledge users from hospitals, of course, is much simpler because that's generally what the clinician, and I don't mean just MDs, it's clinicians of all levels, the therapists, nurses, doctors. And you can have clinicians just as collaborators where really, they're interested and they want to help you out, so they'll give you access to the blood samples or the population, health population or whatever. You can look into that. And of course, the hospitals themselves can be partners. Again, that's the capital P partner, so you've got the organization who's partnering. And they don't necessarily have to have an individual identified. You can work with the hospital writ large without necessarily having an individual on site. Now, I have to tell you that if you're going to partner with the hospital, they're going to want you to have an individual on site, so you can't sort of get away from that. But from CIHR's point of view, you don't necessarily have to have that. So if you're working with clinicians or, again, actually systems, I've mostly covered all of this in the previous one. If they're going to be independent researchers, they have to have an academic appointment that lets them supervise students. That's is part of the definition. That's the stumbling block from a lot of them when people try and get an adjunct appointment. If that doesn't allow that, they cannot be co-applicants from an independent researcher side. As a knowledge user, they simply, again, have to be in a position to actually apply that outcome. And there was a suggestion from Helen where if it's within a unit, they can't necessarily work on their own. You're going to have to allow that time to get working up through the institution or through the hospital. And the collaborator we've already talked about. So the partner, they must commit some cash or in kind. They can't have a letter of support. You can't call them a partner if they're not ponying up some of that cold hard stuff. So, or at least in kind, and it has to be tangible. I suppose you could say free parking. It might actually be quite considerable. You could try it. I'm not sure CIHR would buy that as a significant, but if they parked at a hospital, maybe they'll go for it. It might be good enough. The partners can be included in an integrated role where they are helping shape the research question. They are taking a big part of the shape and the direction of the research. They can also just be an end user role where they're basically saying, yes, we're interested in this. If you create whatever it is that you're working on, we would be happy to try and implement it. So there's options of those roles. In CIHR and their new project scheme, you may actually select integrated knowledge translation or commercialization as a project type. It doesn't change the application or the review, but CIHR has committed to ensuring a certain success rate. They haven't defined certain success rate, but I can tell you it will be low because all success rates at CIHR are low, but for those programs. So if you're in a position to have an integrated partner from their hospital, that's putting you into a pool of at least some protected success. That's a good thing as far as trying to get the money. The good news is almost any CIHR grant can include partnerships with hospitals. In fact, it's probably any, but in fact, I didn't go through every possibility. But they're in the business of health research. Hospitals are in the business of health. You will be able to partner with them. It's wide open as far as that goes. The most obvious ones are the open operating grants, which now are called different things, but the project scheme, which is the one we're piloting now, Absolutely. Encourages partners, and I say they actually have that protected envelope, which we don't know how big it is, but it's there for integrated knowledge translation. The collaborative health research projects can be very good probably for some of the CBB entrants because that is the marriage of NSERC discipline and health discipline research intersected together. You must have an NSERC principal investigator and you must have a health researcher principal investigator to work together. So they start with partnership in mind. So those are also particularly good. And you must have a knowledge translation partner of some kind or commercialization, which encourages work with hospitals. So those are very, very good ones to aim for. There's a big difference between eligible and competitive, especially at CIHR right now with the low success rates. The nice news is with the new project scheme, it's become very flexible around the specifics of partner contributions. You know, it used to have to be, you know, one-to-one match and 75% had to be cash and they had all kinds of rules. Those rules are pretty loose now. I mean, they have to pony up something, but it doesn't have to be a certain ratio or anything else. So it's very broad and very flexible, which is great. However, to actually get funded means that you have to have a very strong partner if you're going to try and pull that off. I mean, it just, as I say, there's eligible and then there's the stuff that might actually get funded. Significant and appropriate cash or in kind. It doesn't have to be just throwing money at it, which is always nice. If you've got somebody throwing money at you, take it. But I won't ever stop that. But you know, people say, well, you know, I'm working with a public health unit. They don't have cash to throw around. Well, that's okay if they can provide the in kind, if they can have staff members that are going to be participating and everything else. If it's appropriate, if they're showing the appropriate engagement and backing it with resources, that's what you're looking for. So don't feel that it has to be cash. Never say no to cash, but it doesn't have to be cash. Free parking, whatever, get that engagement. You want the reviewers to go, yes, this partner really is engaged in this research. Explicit and powerful why and how of engagement. They want to believe why does this partner want to be there? Is it because it's actually the second cousin and you just talked them into signing the letter? Does it match with their strategic plan? We've got a joint research agenda between GRH and Waterloo. Use that. Mention, you know, it shows as part of the two institutions strategic plan. You want to build why is the partner here and be very explicit, not just we just think this is a great idea and it'll help health. No, explicit and powerful so that they believe that the partner really, like, holy cow, this matters to us. Explicit and powerful knowledge user roles. Again, you want the knowledge users at the table who will truly actually be able to translate this somewhere, that can have that impact. You want the right people there. Strong applicant CCVs. If you have co-applicants or principal applicants from hospitals, that's one of the tricks with the community hospitals where I said, you know, we can get adjunct appointments, we can let that happen. But be careful because if they're not part of an academic hospital, their CCVs may not be as strong. It doesn't mean they're not damn good at what they do. They're clinicians, they're doing their job. But they may not have a whole bunch of papers or anything else that's recent that might not be as strong. You might actually want to engage them more as the knowledge user at that point where their CV will bring what they need to the table. Think about that. That's one of the things you have to weigh when you're deciding about the role that you want. This is really reiterating almost all the tips that you heard earlier. It takes time, the process takes time, and clinicians don't necessarily have time. So you have to add that into the process. And I'm saying explicit again, and this deals with part of the dialect of hospitals and everything else. Especially at community hospitals, they are not in the business of applying for research grants. And that's a very peculiar, stress-filled, deadline-fraught activity. And you can't expect clinicians to simply line up and be ready for all of that. Things as simple as the CCVs and ResearchNet registration is not what they're used to doing. And we all know how much academics love the CCV. Who here enjoys the common CV? Show of hands. Yeah, None. So I don't either, okay? So if you've got a clinician who's looking at it going, what the hell is this? And, you know, hi, it's due tomorrow. Can you please do your CCV tonight, please? Please? No, don't do that. In fact, if you can, do it for them. If they are willing to do a sign up and give you a, you know, do a completely singular password so that I can't get into your banking information, and we will upload the information for you, because it's not fun. ResearchNet registration, even that, it takes time. They need time to sit down and do that. It doesn't take a lot of time, but it's not something that's in their day. The letters of support is not something they've written. You've got to help with all those little technicalities and allow time for it. But before you get even to that stage, you have to be absolutely crystal clear in the research project so that they're engaged, they have the research questions, they bought into the research question, they're going to write that strong letter of support because it really matters to them and it hits their strategy. And they have to absolutely understand what their role is. Do they need to have their time paid? You know, they can't, their times are filled. They don't have research time slot. They don't have their 40% part of their life is supposed to be research. They don't have any of that. You need to figure out all of that so you're not surprising them going, well, no, we don't have anything in the budget for that. You just have to find nurses that can give us 4 hours a week. No, you have to get all of that. So the earlier you get that down and then find out that a chair means the equivalent of a patient bed for dialysis. Because if you don't, well, those are the don'ts, where the conversation ends up doing this. And then in the rush of a deadline, all of a sudden you can't pull it off. And the other thing you also have to do is be very explicit about the chances of success. If you're applying to CIHR right now, I keep doing that to people who apply, and I encourage people to apply. I bang that drum, because if you don't apply, you really won't get funded. But if you do apply, you have to understand that you probably won't get funded. What am I supposed to say? It might be a 6% success rate this time. What am I supposed to, it means 6 out of 100 people are going to be funded and the other 94 aren't. I'm hoping it's better than that, but it's probably not going to be a lot better than that. However, that's where we're at. So if you're engaging everybody, you also have to say, and by the way, this is wonderful, and we're going to try and find, and we'll try and find alternate sources to get this paid, but in fact, it might not actually be successful, and don't take it personally. It doesn't hurt to have that conversation too, so that they don't just go, I'm never doing that again as long as I live. I try and say that to researchers too, by the way. Please don't walk away from CHR forever, even though it's tempting. So those are the kinds of things. Give it that time, give it that effort, and don't do it on the timeline of CHR registration is going to be sometime in August, is all I can tell you at the moment, because they haven't announced it yet. You can't wait till sometime in August to have a conversation with the hospital about putting in the application sometime in September. If you want to do that, in fact, we're already starting to run a little short on time. Start today if you want to be doing something with a hospital for CIHR this fall, because it takes that kind of time. You can't wait for all the nitty-gritty to come out, because the grant timeline is far too short. It does not align. Is that a fair statement? It does not align with a hospital timeline, particularly a community hospital timeline that isn't in the research grant application business. I think that's all I got. So.
So now I just want to open the floor to any questions on the second half, or even in the first.
Are you going to answer my question now, Julie?
Oh, sorry.
You know, it sounds like there's been a lot of efforts around coordination, but as much as there was talk about one application, it still sounds like two. And
You are correct.
I'm not sure where the less paperwork actually does come in, because I've got one form going to the hospital, and I've got one. Even if I'm cutting and pasting, there's still the other. There are still two processes as far as I can see.
A little bit, yes. So we're trying to eliminate having to submit. The issue is we have a system here at Waterloo for our ethics review, which is archaic. and old and awful to have to work within. So we are in the process now. We are probably a year at least away from having a new system where then we would be able to simply have our researcher just upload the THREB application form. We're not there yet. So hang tight. We're about a year or so, just a year and a bit away, and we will try to eliminate that. Now, for researchers who are saying, I just can't figure out what to do, we will provide the supports to try to populate our database so we have the information in there that we need that can come from the THREB application form. So if you need help, let us know. But a lot of times what faculty are doing is, of course, asking a student, which is great because we don't always have all the resources available, but having a student do that cut and paste for us. So.
Okay, thanks. And maybe a second question, this may be for Sarah. You talked about submitting first to the research committee at Grand River Hospital, and then in the subsequent month, the THREB committee meets. So my question is, if I submitted something to the research committee and there were questions or there was some modifications requested or there was some information that was needed to be added, does it need to go back, wait for another meeting of the research committee before it can go to the THREB?
No, when your application comes to the research committee, we turn, if the committee is requesting modifications to your application, we would turn that letter around to you within 48 hours. And with the anticipation that would give you then a week to make your modifications. And it's just a confirmation within our office. You send the modifications back in, I say, yes, you've met the requirement.
Okay.
You may now
And it can
proceed
still go ahead to the-
automatically in that same month
Okay,
to go to
that's
THREB.
good. Thank you.
But the caveat is that there's a small percentage of submissions that come into us that require significant change. That does happen, and we have had some researchers go through an additional cycle, and we have, maybe I can count on one hand, which isn't very many, where we've actually had to invite the researcher to come back again and present to the research committee, just because perhaps their application wasn't clear at all. Well, even their research question wasn't clear. Right, so I think that creates, the job of the research committee is to reduce confusion for the researcher, because we understand coming into the hospital sometimes can be unclear and navigating that process. And so it's really to ensure as much success, increasing the probability of success of that initiative. So we had on one occasion, University of Guelph had wanted to do some work with us, and their researcher was going to do some antibiotic-resistant surface testing. And I think there was a misunderstanding between the local investigator, which is the hospital side, and the researcher, that they could just come in and, so if you're a patient, they would just come in and swab your bed rail. It's like, well, you can't really do that. You have, the nursing unit, you must be identifiable, you must have proper ethics approval. There's a number of things that had to happen. And I think that was a bit of a learning for them. And so we try to facilitate that as much as possible through the research committee, or pardon me, the research office, so that there are no surprises when researchers actually come to the research committee. And I would say, and I think it's fair to say that largely, by the time people get to the research committee, they are 9/10 of the way ready to submit, because Sarah will have facilitated them and directed them to the right people. The other thing to say is, internal to the Grand River Hospital, and Sarah alluded to it in her presentation, that application to the research committee is the same form. So we use the same form as THREB. So there isn't another application form you need to fill in. And so if there's modifications that the research committee has asked for, it's modifying that same form, which then goes to THREB. So we, between our two organizations and our association, REB being our board of record, we're pretty clear in terms of what our expectations are, in terms of knowing from the researcher and the local investigator what activity is going to be happening, what information, what patients are going to be involved, how many staff, how many people, all of those factors that need to be, all those T's that need to be crossed and I's dotted.
I have, yeah, is that okay, Paul?
That's okay.
Yeah. Okay, so but I have another question of my own. So in the Grand River, when you actually have the patient, let them to sign the consent form, right? So when lots of data, for example, if I really want to understand the chair, how they move around more efficiently, it's a retrospective study, and how I'm going to deal with the patient consent in that kind of a study. So is there any thought about building into that research component to your patient consent, general patient consent clauses in the hospital?
Right, so there are processes in place already for studies that legitimately make it impossible or not practicable to go and get consent. So if it is a retrospective review of 10 years of data, we are not going to go back and require consent for those patients. And so I think it is a case by case, because I don't want to say that's for everything, but largely there is a process for those considerations.
Okay, any other questions?
I guess I have a question about funding. I'm just curious, the current research collaborations between UWaterloo and GRH, how are they funded, and were they, was there funding available before the project started, or was it through the process of doing the project they came up with some funding?
So anyone talk about their projects and how the funding came about at the beginning?
I can talk about it. So with my particular initiative, there was some funding that the primary investigator had in the beginning, and then GRH also offered in kind.
Is that your answer? Okay. Any other questions? Yep.
What in kind did you offer?
So we had the collaboration with the clinical staff themselves. So we had someone that really was the navigator for the individual that actually asked patient experience questions. And so we utilized that methodology. And then there was in kind through the quality department as well. And many more. Yes, so also decision support, our risk department. So there's significant, the stakeholders that were required to support that initiative, that was the in-kind.
Okay. Any other questions in the audience? No? Okay. Well, first I want to thank everyone for participating in this panel. I thought it was a really great discussion, and a lot of the topics that were addressed were things that I've heard in separate pieces, and it's kind of nice to have it all kind of come together and see how it all fits. So, I mean, the collaboration between Grand River and the hospitals in general with UW is really a passion of mine. Like I've experienced this as a student. I was a PhD student here in mechanical engineering, and reached out to Grand River actually on my own, emailing people and asking if I could just come in and shadow a doctor for a day and stand behind him and see what it's like when they're implanting stents. So that was actually at St. Mary's where I started off. And then now I've seen it on the researcher side, where now I'm trying to help other researchers get the same sort of experience, because I thought it was so valuable. It gives you like a completely different view on what you're doing, and seeing the patient lying there and knowing that what you're working on will make that person healthier, have them go home and go back to their families. So that's why I'm pretty passionate about getting this going, getting the collaborations going, getting everyone involved, and the process is long. It's a lot of paperwork. Even to shadow a doctor for a day is a lot of paperwork. And there's a lot of PowerPoint slides that you have to look at to learn all about the rules in the hospital and the language and such like that, but totally worth it. absolutely worth it. And the researchers that are here, I would actually encourage to ask you to encourage your students to reach out and do some of the shadowing opportunities. Like if it's not a full research project, but to just go in and see what's going on in a hospital every day. I think it's very valuable. So, yep. Sorry.
I'm not sure it was mentioned. I'm not sure it was mentioned, but did anybody talk about the facilities that are available for researchers at Grand River?
No, we didn't. Great point. Sarah, do you want to talk about it a little bit?
We have made dedicated office space at both the KW campus and the Freeport campus for researchers who are actively engaged in research at the hospital. So on the main campus, we have 6 independent workstations as well as a meeting space, and 4 at the Freeport campus as well.
I can attest, it's the most beautiful. A very nice view, the ninth floor, and one of their best facility, and also the internet and the brand new furniture, and now you have a big screen as well, because my team actually is there regularly, and for 2 of our projects, but very nice. And again, Grand River made it very easy to go through those process and get or even including free parking if you're students. It's very easy. They will guide you through those process. They treat students much better than they treat me. I have to pay. Yeah, students get it for free.
Nice. Yep, and as Sarah's mentioned, so I run the Pizza with the Prof sessions at the Freeport campus. And so in the fall, we'll be starting that up again, and I'll be reaching out to researchers. If you don't contact me, I will be at your door asking you if you would like to give a presentation there, because I think the feedback that comes back from the clinical staff is it's awesome. Like it's informal, they tell you what they think, they straight out, like no tiptoeing around things, and I think that is very, very valuable. So, and you can, if you want, you can talk to some of our past speakers there, and they can tell you about the whole experience as well. So. Thank you very much. We still have the room for a little bit, so if anyone wants to come up and ask some individual questions of the panel members, feel free. So, thank you.